A very good morning and greetings to one and all assembled here. It gives me immense pleasure to extend to you a very warm welcome on behalf of the Department of Oral Pathology and Microbiology, Vivekananda Dental College for Women, who has clubbed us, all of us, for this virtual CDE program. Oral pathology occupies a unique position in diagnosing challenging diseases like head and neck cancers by providing confirmatory evidences and navigates the surgeons for better management of patients. I am sure this program will enlighten and broaden our perspective regarding the subject and enlighten us. To welcome is to show honor. Now, I would like to invite Dr. Elayampalayam, Professor, Department of Oral Pathology, Vivekananda Dental College, to deliver the welcome address.
Good morning to everyone. On behalf of our Department of Oral Pathology and Microbiology, I am here to present the welcome speech for the CD program on Pathology Stories Unfolded. It's my honor to welcome our respected Chairman, Sir, our Dean and Advisor Captain, Dr. S. Vivekananda, Sir, our Principal and Organizing Chairman, Dr. Balan, Sir. I also take this opportunity to welcome our guest speaker, Dr. Priya from BS Dental College and Hospital. I also welcome our staff members and students for this occasion. I once again welcome one and all for this CD program. Thank you.
Thank you, sir, for the warm welcome. Now I request Dr. Maheshwaran, Professor, Department of Oral Pathology, Vivekananda Dental College, to introduce our guest speakers today.
Good morning, everyone. It is my honor and privilege to introduce the guest speaker of the CDE program, Dr. Priya Madam. Dr. Priya is presently working as professor in the Department of Oral Pathology, VS Dental College, Bangalore. She has completed BDS in Cards Davangere and MDS Oral Pathology in VS Dental College. Madam is having more than 16 years of teaching experience, and Madam is currently pursuing PhD under Rajiv Gandhi University of Health Science on microRNA in oral cancer. Dr. Priya Madam has around 25 research publications in national and international journals. She has also contributed a lot to our association journal as co-editor for past two years. She is also peer reviewer in many national and international journals. Madam has delivered many guest lectures at state and national forums. She was awarded Best Scientific Paper Award at 8th Annual Conference of Asian Society of Oral and Maxillofacial Pathology in the year 2017. She proved to be a good quiz master at our national conference held in Kerala. Madam is also recognized as a subject expert for dental MCQ book preparation by the Macula Healthcare Private Limited, Bangalore. With these few words, I welcome ma'am to the CDE program. Thank you, ma'am.
Thank you for those kind words. I would like to share my screen.
Thank you, sir, for the brief introduction of an eminent speaker. And now, I am pleasured and honored to invite Dr. Priya N.S., Professor, Department of Oral Pathology, VS Dental College, Bangalore, to share her knowledge and experiences and flood light on pathology stories unfolded.
Can I start?
Yes, ma'am.
Okay. Good morning, everyone. And it's my pleasure to be with you all today to share a bit of my experience in the form of stories pertaining to the subject of oral pathology. I take this opportunity to thank the management, the principal of Vivekananda Dental College for Women, and especially Dr. Ganapati sir, Professor and Head, Dr. Yamuna, and other staff members of Department of Oral Pathology for me the scientific and to be a part of the CD program. I strongly consider that oral pathology is one of the diversified and spectacular specialty in dentistry. Oral pathology is a integrative science which acts as a bridge between the basics and the clinical science. So, with that in mind, I have tried attempting to compile 7 case scenarios in the form of stories. Hope you like the format of the presentation. To begin with the story of an ulcer. The second story is about an impacted tooth and its association with a few odontogenic cystic tumors. Third story is about a rare malignant salivary gland tumor involving the parotid gland. Fourth story is about a smooth muscle and how it leads to the formation of a benign tumor, that is leiomyoma. Fifth story is about osteopetrosis, which causes brittle bone, and it is a rare disease for the dentist. And sixth story is about a clear cell. I'll be talking about one of the odontogenic tumor which shows predominant clear cell morphology. And lastly, the famous black fungus, as we all know, know it as mucormycosis. So let us begin story 1. As you all know, the definition of ulcer. What is an ulcer? Ulcer is a break in the continuity of epithelium with molecular death of the epithelium. And ulcerations are characterized by defects in the epithelium or in the connective tissue or both. And if you can recollect the parts of an ulcer, there is margin, there is edge, there is floor, and the base. So what is a margin? Margin is the point where ulcer joins the normal epithelium. Edge is the area between margin and the floor. Floor is the area which is, it is the exposed surface of an ulcer. And base is the area on which ulcer rests. So floor is something which we see, base is something we feel. That is the difference. One is seen, another is felt. And there are certain characteristics for an ulcer. Certain ulcers are site specific. To give an example, the rodent ulcer or basal cell carcinoma is common in the midface region, and syphilitic ulcers are common in the upper lip. So certain ulcers will be site specific and number can vary. Most of the bacterial ulcers caused due to bacterial infection like syphilitic and tuberculous ulcer are solitary in nature. They're single, but viral associated ulcers and immunologically mediated ulcers are multiple in number. And size can vary depending upon with the various etiological agents. And the shape, again, the irregular shape of an ulcer give a clue to the malignant ulcer, and other ulcers can be round, and even immune-related ulcers can be little irregular. And certain ulcers are painful, certain ulcers are painless, especially the vesiculobullous lesions and viral infections. This is just to show you how the floor appears. So floor can be covered with the red granulation tissue. You can see the redness here, or it can be covered with the slough or the necrotic tissue. So this is to show you the shape of an ulcer. It can be round and regular, or it can be irregular, as we see in a squamous cell carcinoma. This is involving the dorsum of the tongue. So coming to the types of edges. So edges can be sloping edge, as we see in Ealing ulcer or tropical ulcer. Undermined edges are characteristic of tuberculosis. Punched out edges are seen in syphilis and even diabetic ulcers. Raised and beaded ulcers are seen in basal cell carcinoma. Then everted and indurated ulcers, everted and indurated borders are seen in squamous cell carcinoma. You can classify ulcers based on the healing time, duration, and the etiology. If the ulcers heal within 3 weeks, they are healing ulcers. If they take more time, it can be non-healing ulcer. And chronic ulcer, if the duration is more than 12 weeks, it is chronic ulcer. If it is less than 12 weeks, it is acute ulcer. And there are various etiological agents for ulcer, and ulceration is a common presenting sign of wide spectrum of diseases. So what causes an ulcer? It can be infections in the form of bacterial infection, viral infection, or fungal infection, or it can be a nutritional deficiency, iron deficiency, anemia, or vitamin B deficiency, etc. Common cause is trauma induced by the tooth and other things. We'll talk about it. Then immunological are immune mediated disorders like pemphigus, pemphigoid, lichen planus, aphthous ulcers, etc. And lastly, the malignant ulcers, mainly oral squamous cell carcinomas present as ulcers. I will try to give example under each category, how it appears and what are its characteristics. So this is an example of syphilitic ulcer, single ulcer on the soft palate, but it can also involve lip and tongue. So the color can vary. It can be red or purple or sometimes brown. And patients with syphilis, they may demonstrate cervical lymphadenopathy, single ulcers. And this is an example of herpetic ulcer. These ulcers are preceded by vesicles, and there will be prodromal symptoms like fever, headache, tiredness. And once the vesicles are formed, they can rupture and they can coalesce and they form ulcers. They're painful ulcers. They can involve any part of the oral cavity. Here it is involving the posterior part of the oral cavity, oropharynx and tonsillar area. They are multiple. They have scallop borders and erythematous hollow. And then this is an example of histoplasmosis, a deep fungal infection involving the dorsum of the tongue. So it is a single ulcer, solitary ulcer. They are usually large, deep ulcers, and you can see the necrotic slough in the floor. It can also involve the palate. Traumatic ulcers are the commonest among all the ulcers. They can be caused by mechanical damage. The damage can be in the form of sharp tooth or the sharp footstuff, or accidental biting can occur during talking, sleeping, and other damage can be due to heat and chemicals. So this is an example of a chemical burn. Patient has kept the aspirin tablet or topical application of aspirin has caused the ulcer in the implant site. You can see ulcer here also, here also. So this is an example of aspirin burn. Then sometimes the after anesthesia, the ulcer formation can be noted. It is called post-anesthetic ulceration. The borders are slightly raised and there is a slough, yellowish pseudomembrane that can be easily peeled off. And there is a special entity called tuxae, that is traumatic ulcerative granuloma with stromal eosinophilia. Etiology is trauma, but it occurs on the ventral surface of the tongue, regular ulcer. And this is an example of sublingual ulceration caused due to natal teeth. So this is called Riga Fede disease. So this is again due to trauma from the natal teeth. So these are the examples of traumatic ulcers. The traumatic ulcers, they persist only for a few days to weeks and they heal within 10 days. So that's a characteristic for traumatic ulcer. Next group is immune mediated ulcers. These ulcers characteristically show three things. That is, they relapse, they persist, and they frequently recur. This point is very important when you take case history, and it also helps in the differential diagnosis of ulcers. They relapse and they persist and they recur. So the examples of immune mediated ulcers are aphthous ulcers. So it can, because it is recurrent, it is called recurrent aphthous ulcer. There are three forms: major, minor, and herpetiform. So aphthous ulcers usually occur on the non-keratinizing surface. So it is the inner aspect of the lip, so lining mucosa. There will be red halo, and the size can vary between major and minor. Lichen planus, ulcer is seen in the erosive type. Along with that, there will be a white striae. We call it Wickham striae. And this is erythema multiforme, where you can see the ulcers with crusting on the lip. So erythema multiforme, in erythema multiforme, HSV has been implicated in the recurrent form, and it is also linked to the medications, NSAID, antiviral, and antibiotics. Around 10 to 50% of the patients, they are linked to the use of medications. Then these two are example of pemphigus vulgaris and pemphigoid. So pemphigus vulgaris can appear on the buccal mucosa. It can involve gingiva. In gingiva, it will be like desquamative gingivitis. That means it looks like all the gingiva is peeling off, generalized gingivitis form. And membrane pemphigoid in the oral cavity, when the oral mucous membrane is involved, it usually involves gingiva. So these are the various types of immune-mediated ulcers. They are multiple, especially MMP and PV, and erythema multiforme. Vesicles can be formed, and striae is known as lichen planus, desquamative gingivitis in pemphigus vulgaris. They are shallow, irregular ulcers. There is something called plasma cell gingivitis, which clinically appears as an ulcer. It can be a single ulcer, or it can be multiple ulcers covering the gingiva. So what is the reason for this plasma cell gingivitis? As the name suggests, there is proliferation of the plasma cells. This is histopathology of one of our own case, where you can see this surface epithelium, and in underlying connective tissue shows proliferation of the plasma cells. So what is the reason for the proliferation of the plasma cells? It is an hypersensitivity reaction to some allergen or antigen. So what is that allergen? It can be a toothpaste, chewing gum, mint, or cinnamon, pepper, and chili. So when case history, is there any recent change of toothpaste? Even herbal toothpaste can cause some reaction, act as an allergen. So it can be single or multiple depending upon what allergen has touched the mucosal surface. So shallow ulcers in the later stages can occur, and it can also involve the angle of the mouth, and it is self-limiting. No treatment is required if the allergen is removed. So this you should remember. It's called plasma cell gingivitis, caused due to some allergens. Malignant ulcers, usually squamous cell carcinoma, can appear like an ulcer or ulceroproliferative growth. The borders will be indurated, and definitely there will be habit history, smoking habit or tobacco chewing habit. Ulcers are painful and they don't heal within 3 weeks, and definitely biopsy is mandatory for the definitive diagnosis. And the outline of an ulcer will be irregular with elevated margins. So in the maxilla, in the posterior part of the maxilla, sometimes there will be some lesion, one lesion called necrotizing silometaplasia. So that mimics squamous cell carcinoma. Again, biopsy will help us identify the both. And this is the histopathology of squamous cell carcinoma showing abundant keratin pus. Come to the investigations. It is in general, the investigations depend on the type of the ulcer, or depending upon the etiology. Hematological examination, CBC, complete blood count, is sometimes required. When you're suspecting anemia, CBC is required. And if you're suspecting tuberculosis, Mantox test And if you're suspecting syphilis, serological tests are done. Then swab is required sometimes for the cytology and for the culture of any bacteria and fungus. Biopsy plays a major role in diagnosing oral ulcers caused by oral cancer or squamous cell carcinoma. I'll try to give 2 examples of ulcers, our own cases. Case 1, a 10-day-old baby presented to the pediatric department. Mother complained of feeding difficulty and the baby was continuously crying. On examination on the surface of the tongue, there was a huge ulcer and there were teeth present. The baby was 10 days old, infant, and there were teeth present. So this was considered to be the natal teeth, and this was considered to be Riga Fede disease. So when there is sublingual ulceration caused by natal teeth, we call it Riga Fede disease. Riga Fede is name of the pathologist who described the histopathology of ulcer. So the challenge was to the pedodontist how to handle this. So first thing, we have to find out whether it is a deciduous dentition, predeciduous dentition, or the natal teeth. It was little mobile, grade 1 mobile, and you can't just wait it, and it was difficult to take the X-ray for this baby. So pedodontist decided to extract the tooth. So what are the precautions to be taken? Anesthetic gel can be applied on the gum pad and followed by local anesthesia. Syringe can be used. It will be very thin, so it is comfortable for the baby. And once the tooth is removed, the bleeding has to be controlled. There is a general protocol that vitamin K is prescribed at birth, but that should be checked before extraction. Otherwise, administration of vitamin K should be done. So that I'll speak to you later. So this is an extracted natal teeth. So the size and the shape of natal teeth resembles primary dentition, but the color of the natal teeth will be more yellowish, and root formation is not evident for the natal teeth. So depending upon the morphology of the natal teeth, Hebble has classified natal teeth into 4 clinical categories. The first one is shell-shaped crown. It is poorly fixed to the alveolus by gingival tissue and there is no root. The second type is solid crown, poorly fixed to the alveolus by gingival tissue and little or no root. Third is erosion of the incisal margin of the crown through gingival tissue. Fourth is edema of gingival tissue with an unerupted but palpable tooth. So it is not very difficult to extract the tooth because most of the times they are poorly fixed to the alveolus. So this is Ebling's classification of natal teeth. So what is the learning point from this case? One thing, you have to handle the baby cautiously, and it is safer to wait until a child is 10 days old before extracting the tooth. The reason being, to wait for the commensal flora of the intestine to become established and to produce vitamin K, which is essential for the production of prothrombin in the liver. Otherwise, if you can't wait, then prophylactic administration of vitamin K is suggested. So 0.51 is administered intramuscularly to the baby as a part of immediate medical care to prevent hemorrhage. Case 2, 30-year-old male presented with multiple ulcers and vesicles along with burning sensation from past 6 months. And he gave history of fever 6 months back, and he was chewing tobacco occasionally. So since he gave history of fever, you can the conclusion, is it viral or is it vesiculobullous lesion? But viral infections will have a prodromal symptom of fever just 1 week before. So is it viral or is it vesiculobullous lesion? So for viral infection, there will be prodromal symptoms, high-grade fever, painful ulcers, and they heal quickly and they bleed easily, and duration also matters. Whereas for vesiculobullous lesion, that is pemphigus and pemphigoid, also preceded by vesicles. They are multiple. They can involve any part of the oral cavity, but you should ask for the relapse history or recurrent history. Okay, so that gives a clue to the vesiculobullous lesion. And cytology also helps in diagnosing the two. This is the smear of the same patient. In the smear, you can see squamated cells, superficial cells with abundant cytoplasm and nucleus, and some cells are small and they are round. Here, these cells are polygonal and these cells are round. So these round cells are called acantholytic cells or Zank cells. In this photomicrograph, you can see in a background lot of neutrophils and then round cells, Zank cells. So these Zank cells are seen both in vesiculobullous lesion and herpetic lesion. But there is a criteria to consider that to be a viral associated lesion. In the cytology, in viral infections, especially HSV, you can see ballooning degeneration and the margination of the nuclear chromatin. This is the cytoplasm. This is the nuclear outline. Inside the nucleus, you can see blue dots. So these blue dots represents chromatin and they are towards the margin of the nuclear membrane. So that is characteristically seen for viral infection. And also the nucleus is homogeneous here, ground glass appearance we call it, and nucleus come together like a molding, nuclear molding, and multinucleation is a characteristic feature of HSV infection. So cytology play a role in identifying the two. In our case, there were no such ballooning degeneration, and then a biopsy also confirmed it to be pemphigus vulgaris. This is the decision tree of oral ulcerative lesions. Oral ulcers can be acute ulcer, chronic ulcer, or recurrent ulcers. So acute ulcers can be further single ulcers or multiple ulcer. The examples of solitary ulcers are traumatic ulcer and necrotizing xylometaplasia, this I mentioned. Then multiple ulcers are usually viral associated ulcers cause, that is primary herpetic gingival stomatitis or herpangina, and also plasma cell stomatitis or gingivitis and hypersensitivity reactions. Chronic ulcers, solitary ulcers again, bacterial infections like TB, syphilis, and fungal infection like deep fungal histoplasmosis, they appear as a single ulcers. And multiple ulcers are immune-related lesions like pemphigus, lichen planus, mucous membrane pemphigoid, etc. Then recurrent ulcers can be solitary or multiple, and the examples are RAS, recurrent herpes stomatitis, Behçet's disease, and herpes-associated erythema multiforme. That's about the story one. Moving on to the story of an impacted tooth. What is an impacted teeth? When do you call it to be an impacted teeth? An impacted tooth is completely or partially covered by mucosa and bone for more than 2 years following physiological eruption time. So most prevalent impacted tooth is third molar and followed by maxillary canine and then mandibular canine. So let us see the impact of an impacted tooth. We'll start with etiology of an impacted tooth, how to evaluate an impacted tooth, what are the various imaging modalities, what are the associated pathologies of an impacted tooth, and is there any syndrome association? So, etiology for impacted tooth is multifactorial. It can be due to local factors and systemic factors. So local factors are lack of space in the dental arch if the tooth is dilacerated, or if there is any trauma to the teeth, both primary and permanent, or ankylosis of the primary teeth, or if there is any mesial drift of teeth resulting from premature loss of primary teeth, or ectopic position, abnormal positioning of the tooth buds during development. And lastly, inflammatory diseases or pathological lesions involving that particular tooth. So all these can lead to impaction. Then systemic factors like malnutrition, anemia, rickets, syphilis, tuberculosis, and lastly, genetic factors may also play a role. So this is the etiology for impacted tooth. How do we evaluate impacted tooth? It is inside the bone. Most of the times, only the crown part is emerging into the oral cavity. So you will take the help of the radiograph. Periapical radiographs are used. Panoramic radiographs are frequently used in the routine examination, but OPG or panoramic radiography is employed as the primary imaging technique. Nowadays, people are using CBCT, that is cone beam computed tomography. It provides a precise and accurate information better than OPG. I will tell you how it is superior than OPG. So this is an OPG where you can see impaction of all four eights. Just as an example, one CBCT report. So there is partially impacted 8 year, 3/8. So look at the amount of information CBCT gives. This red line represents the inferior alveolar nerve. You can check the association of the impacted tooth with the nerve, and it also measures the mesial root measurement is given here 19.5. Then distal root, whether mesial root is fused to the distal root, and what is the crown width, what is the root width, and how much is the crestal bone present, and whether there is dilaceration. All these things. Can I continue? Yeah, all the points can be made out through CBCT, and also there is option for 3D imaging. Am I audible? Is there any problem?
Yes, ma'am, you are audible.
Yeah, I can continue, right?
Yes, ma'am. You can continue.
So this is a CBCT report with the imaging. So it is definitely superior and it is precise. So it also tells the dilaceration is towards buccal, or the impaction is towards buccal side or lingual side. So which you do not get that info from OPG. That is CBCT. Then what are the associated pathologies with respect to an impacted tooth? Since impacted tooth will be close to the adjacent tooth, there will be complications regarding the decay of that particular tooth and periodontal diseases, marginal bone loss, and resorption of the adjacent teeth due to pressure. That is one thing. The other thing is impacted tooth can give rise to cyst and tumors. In 24% of the cases, impacted tooth is associated with cyst, followed by CEOC, that is calcifying epithelial odontogenic cyst, and OKC. Tumors like adenomatoid odontogenic tumor, odontome, ameloblastoma, both unicystic and solid multicystic, are associated with impacted tooth. Then ameloblastic fibroma too, and rarely central giant cell granuloma. What are the syndromes associated with multiple impacted tooth? It is cleidocranial dysplasia, Gardner syndrome, Down syndrome, Zimmerman-Leban syndrome, and Noonan syndrome. one of the important component of an impacted tooth is the surrounding soft tissue, that is dental follicle. So sometimes we will be wondering, is it just the hypoplastic dental follicle or it is early dentigerous cyst? So there is a radiographic width to consider it to be dentigerous cyst. If it exceeds more than 4 mm, you call it dentigerous cyst. So here is one impacted tooth, and you can see around, so that represents dental follicle. So what is the histology of the dental follicle? So is dental follicle always lined by epithelium? Sometimes yes, sometimes no. So the lining resembles reduced enamel epithelium, and the fibrous tissue will be present. Fibrous tissue or myxoid tissue. You can see the difference between the two. Myxoid tissue is whitish here with part, and this is the fibrous tissue, pink tissue. And in that fibrous tissue, you can sometimes see odontogenic crest. So you can see 3 odontogenic crest here. There is one more here. Sometimes calcifications are seen. So this is the histology of dental follicle. So radiographically, there will be a radiolucent rim around the impacted tooth. Let us look at the 4 cases where there is unerupted, or you can call it impacted tooth involved. So this is an OPG where you can see the deciduous teeth decayed, and there is unerupted premolar, and there is radiolucency involving the primary teeth, unerupted tooth, and also the molar tooth here, permanent first molar. So what are the possibilities? What are the radiological diagnosis? Radicular cyst because there is a primary teeth is decayed, or it can be dentigerous cyst because it is involving the crown and the lateral portion of the unerupted tooth, or it can be AOT because it is involving the unerupted tooth. These are the possibilities. So the teeth was extracted, along with that the cystic specimen was enucleated. So here to take a clue whether the cystic lining is attached to the primary teeth or is it attached to the and it was tissue sections were taken separately. The tissue from here, these 2 regions were processed separately, and that showed a radicular cyst lining, lumen, and this is the non-keratinized stratified squamous epithelium with arcading and lot of inflammation in the wall. So this was radicular cyst, an inflammatory cyst. Again, you can see lot of inflammatory cells and areas of hemorrhage. So the diagnosis was radicular cyst. The tissue which was processed close to the crown of this showed dental follicle. You can see myxoid area and 1 or 2 small rests here. So that was dental follicle. There was no lining mimicking the dentigerous cyst. So when you come across such things, there is deciduous teeth which is decayed, and permanent teeth which is not erupted, a care should be taken when you process the tissue and come to the diagnosis. Because sometimes inflammation can lead to changes in the morphology of the regular cystic lining. So in that case, it helps in the diagnosis. Case 2, 20-year young male patient with the duration of 6 months presented with swelling in the mandibular region. Radiographically, it was multilocular radiolucency, and there impacted 4-3 and 4-4, and plus there was supernumerary teeth. Okay, you can also see the scalloping interdentally. So we thought of OKC, ameloblastoma, central giant cell granuloma, and aneurysmal bone cyst, going by the multilocular radiolucency. Then FNAC was tried, aspirated fluid was examined. In the aspiration, when it was smeared and observed under microscope, we could see some calcifications, these blue calcifications. we usually don't come across the presence of calcification in FNAC. So we were thinking which lesion shows ossification. Is it ossifying fibroma? But the radiology doesn't. So in FNAC, we could see the calcification. In biopsy, the cystic lining resembled odontogenic keratosis, the basal cells palisading and parakeratinized stratified squamous epithelium. And also in the wall of the cyst, we could see some calcifications. So it was a case of OKC with calcification. So, but there were impacted 4344 and also one supernumerary T. Case 3, 15-year-old female patient presented with pain and pus discharge. The unerupted ectopic 2-8 was noted. It was located in the maxillary sinus. The other 8s were also impacted, and 2-8 was sitting in maxillary sinus. The CBCT image of the 2-8. In FNAC, it just showed squames and unstained smear showed cholesterol crystals. These are the box-shaped cholesterol crystals with one edge cut off. So this just indicates that it is an inflamed cyst. Need not be radicular cyst always, but any developmental cyst with inflammation can show cholesterol crystals. And biopsy, again, it was the lining resembled odontogenic keratosis, parakeratinized stratified squamous epithelium with basal cell palisading. Wall showed inflammation, and we gave a diagnosis of OKC in association with ectopic tooth. And the lining of the maxillary sinus was also there. So it showed pseudostratified ciliated columnar epithelium, the normal sinus lining. So you can think that it could be dentigerous cyst because it is impacted and radiolucency surrounding it, but it turned out to be OKC. Fourth case, look at the OPG here. There is a grossly distracted first molar, impacted third molar, and there is one extra tooth here. I'm saying extra because premolars are already there, first and second premolar. There is one more premolar-like tooth sitting here. And when it was extracted, it resembled the premolar. The morphology resembled premolar. You can call it supplementary supernumerary teeth. And radiolucency was surrounding the grossly distracted. And there was a kind of radiolucency surrounding the impacted supernumerary teeth. So what are the possibilities? It can be radicular cyst. It can be dentigerous cyst surrounding this and going like this, or it can be OKC. So this is the gross appearance of the extracted tooth with the adjacent follicular space, and this is the enucleated cystic mass. So histologically, the lining resembled radicular cyst, non-keratinizing stratified squamous epithelium with lot of inflammation in the wall. So the diagnosis was radicular cyst with impacted supplementary supernumerary teeth. So these are the associated pathologies with respect to impacted tooth. Moving on to the third story, that is story of a parotid swelling. So broad spectrum of pathological conditions can affect the parotid gland in the form of unilateral swellings or bilateral swellings. So unilateral swellings are more frequently seen compared to the bilateral swellings. So the examples of unilateral parotid swellings can be acute and chronic. Suppurative parotitis and xylolithiasis are examples of acute unilateral parotid swellings. Chronic ones are tumors and bacterial parotitis, whereas bilateral parotid swellings can be due to inflammatory conditions, mainly viral infections like mumps, HIV, and chronic xylodinitis, and non-inflammatory conditions like Sjogren's syndrome, sarcoidosis, vaginous granulomatosis, and chimeras. So parotid swellings can be associated with facial nerve paralysis in case of carcinoma involving the parotid gland, and so benign lesions like Sjogren's syndrome and sarcoidosis. The benign parotid swellings, they do not involve the skin, and there is no lymphadenopathy and no facial nerve paralysis. They are chronic in nature. It will be slow growing and it will be there for years, unilateral diffuse swellings. Whereas malignant parotid swellings will have all the features like lymphadenopathy, skin involvement, and facial nerve paralysis. Again, they are chronic, and sometimes there is rapid growth and pain in the swelling. So that's the clue for malignant parotid swelling. So this is just an approach to the salivary parotid gland tumors. So is the swelling diffuse or discrete? Discrete ones are usually neoplasms where you have to further investigate with the FNAB or CT scans. Diffuse swellings can be bilateral or unilateral. And you should know what are the parotid swellings which occur bilaterally and which are the parotid swellings which occur unilaterally. Warthin's tumor, the benign tumor, can occur bilaterally. So like that, you should have a clue that which are the bilateral parotid swellings. Then is it acute or chronic? Is it painful or painless? Is it occurring in childhood or is it occurring in adults? Is it granulomatous or non-granulomatous? So all these points will give a clue to the diagnosis. So let us discuss a case of a 65-year-old female patient with a swelling in the left parotid region. She says duration is 2 months, but pain was present in that region since 3 months. She gave history of surgery performed in the same region 10 years back, but she had no documents suggestive of any diagnosis. What was the earlier lesion about? And intraorally, there was no swelling. Extraoral swelling was evident, and it was a discrete swelling in the left facial region extending to superiorly up to the zygomatic region, inferiorly up to the lower border of the mandible, laterally in the up from the mastoid region to medially. It was almost 2 centimeters from the corner of the mouth, and the skin appeared normal with no surface ulceration, firm in palpation, and submandibular group of lymph nodes, and they were fixed, and there was fixity of lymph nodes of level 1, 2, 3, and 5. Cytology was performed and it showed some undifferentiated cells and some basaloid looking cells with some secretory material in the background. So it was given as malignant salivary gland tumor. Usually biopsy is not indicated for parotid swelling. FNAB or FNAC is indicated. So it was excised considering it to be a malignant tumor with SOND. Suprahomoid neck dissection was also performed because lymph nodes were involved. They were fixed to, there was fixity. So histologically, it showed the whole parotid gland was removed and the whole gland was infiltrated with the tumor cells. So it was an infiltrative tumor mass comprising of pleomorphic cells, epithelial cells arranged in various patterns. They were arranged in sheets, nest, and papillary pattern. You can see the papillary projections here. Considered to be the carcinomatous component where it shows adenocarcinoma not otherwise specified. That means if areas are not mimicking area of tumor, for example, if it is not mimicking adenoid cystic carcinoma, it is not mimicking epidermoid carcinoma, the malignant salivary gland tumors, NOS word is used, that is not otherwise specified. After thorough examination, in some area, there was ductal differentiation with the eosinophilic coagulum in the center. This area mimicked like pleomorphic adenoma histologically. So there were remnants of the duct and it showed ductal differentiation just like pleomorphic adenoma, and it was definitely malignant because you can see the mitotic figures. There were normal mitotic figures, abnormal mitotic figures, and it was infiltrating. So this was the gross pictures of the excised parotid gland with the lymph node. You can see parotid lymph node measured around 1.9 centimeter, submandibular lymph nodes measured around 2.5 centimeter, level 3 group upper jugular measured around 1.7 centimeter, level 5 measured 1 centimeter. So after examination of all the lymph nodes, there was no extracapsular spread. It was just closed, tumor islands were close to the capsule. Margins were infiltrative and positive with no skin involvement. So if you look at this information, parotid lymph nodes, 10 were dissected, out of which 3 showed metastatic tumor. This is the cross section of the lymph node. You can see the capsule and the rim of normal lymphocytes. And here you can see the tumor islands going close to the capsule. And here also capsule is, and the tumor is completely involved in the lymph node. This is a hyper view of necrotic areas and pleomorphic cells involving the lymph nodes. Submandibular group of lymph nodes, out of 15, 13 were involved. Level 3, all 7 lymph nodes showed metastasis. Level 5 also showed metastasis. So it was a very infiltrative, aggressive tumor, and the diagnosis was carcinoma X pleomorphic adenoma. Patient gave an history of some lesion in that region, and histologically some areas showed pleomorphic adenoma like. So the diagnosis was carcinoma X pleomorphic adenoma. So it is defined as a carcinoma arising from a primary de novo or recurrent benign pleomorphic adenoma, or carcinoma X pleomorphic adenoma arising from the pre-existing or from the remnants of pleomorphic adenoma. Carcinosarcoma is a true malignant mixed tumor where, along with epithelial component, malignant connective tissue part will also be there. And the third one is metastasizing pleomorphic adenoma. So this carcinoma X pleomorphic adenoma has female predilection, occurs in elderly. Parotid gland is majorly involved. Minor salivary glands are also involved. It appears like a firm mass in the parotid gland region, asymptomatic in the beginning, later pain, patient nerve palsy, skin ulceration, and lymphadenopathy is seen. So immunohistochemistry closely resembles for pleomorphic adenoma, demonstrating antigen reactivity for EMA, cell, and positive for PCNA, Ki67 and P53. For malignant tumor, percentage of Ki67 matters, and the prognosis is very poor despite aggressive treatment. We lost this patient within 6 months after surgery. Survival rate is just 40%, the 5-year survival rate. So though we don't come across the salivary gland tumors to be so aggressive involving the lymph, but the tumors can attach to lymph nodes and can be aggressive. So it involves lots of lymph nodes. The next story is about smooth muscle cell. What is a smooth muscle? Smooth muscle is one which is spindle shaped, and when you describe a cell, we describe cytoplasm, cell border, nucleus. So for smooth muscle, cytoplasm is homogeneously pink, cell borders are distinctly made out, nucleus is long and has round ends, and the intercellular spaces between the two smooth muscle cells. So any characteristic fusiform shaped cell with a central nucleus arranged in fascicle or a bundle is called, it suggests smooth muscle differentiation. So many cells are spindle. For example, Schwann cells are spindle in nature, fibroblasts are spindle in nature, then myofibroblasts are spindle in nature. So how do we identify a smooth muscle? So that is, the ends are round and it mimics cigar shape, and there will be intercellular spaces present. And in HND, if you are not able to make out what type of cell is that, you can take the help of special stain. Some students are here, and if you recollect the first year record book, you have written about some special stains, Masson trichrome stain. It is helpful to differentiate muscle from collagen, and PTAH stain also enhances the muscle fibers. IHC definitely helps, that is alpha smooth muscle actin and caldesmon and calponin. So these are the smooth muscle cells. So this is a mesenteric stain. It is called trichrome because 3 colors are enhanced: blue, pink, and green. Smooth muscle will take a pink color, collagen will take up either blue or green, and nucleus will take a blue. So you can easily differentiate between the smooth muscle and the fibroblast and the collagen. So do we see smooth muscle in the oral cavity? In certain places. Most of the muscles in the oral cavity are skeletal muscle. If you take an example of tongue, it is made up of completely skeletal muscles of mastication, and the muscles in the deeper area of buccal mucosa, all are skeletal muscles. So where do we find the smooth muscle? So it is seen in 3 areas: tunica, media of the blood vessels. So blood vessels will have 3 layers: intima, media, and adventitia. So smooth muscle coating, you can see the spindle shaped cells here. So this is smooth muscle. So that is present in the tunica media. Then ductus lingualis, and thirdly around circumvallate papilla region, you can see smooth muscle. So blood vessels are seen everywhere in the oral cavity. So you can see smooth muscle proliferation in the form of leiomyoma in oral cavity. So lip, tongue, cheeks, palate, gingiva, and even bone is involved. So what are the types of smooth muscle tumors occurring in oral cavity? So it can be smooth muscle hamartoma, or benign tumor like leiomyoma, or malignant tumor like leiomyosarcoma. And some have argued that myofibroma is a smooth muscle tumor rather than a fibroblastic tumor. So most common is leiomyoma. So we had a case of leiomyoma occurring in the midface region. So 38-year-old male patient reported with a swelling in the left cheek region, and it was slow growing tumor. The duration was 12 years. Patient had that swelling for the past 12 years. Since it was asymptomatic, he didn't bother to visit a dentist. And it was small initially and gradually increased, and he started developing pain 4 years back. It was a diffuse swelling extending 1 centimeter from the lobe of the ear to 1 centimeter from the aloe of the nose. Surface was normal, intact, and it was firm in consistency. So clinical DDs were neurofibroma, neurilemoma, fibrocystocytoma, nodular fasciitis, and leiomyosarcoma, and leiomyoma can be considered. FNAC was performed, and it showed spindle-shaped cells, tapering ends, spindle-shaped cells. These are RBCs, and some areas it was little hyperchromatic but benign looking cell. So it was given as benign spindle cell tumor, and it was excised, considered to be one of the spindle cell tumors. So this is the gross appearance. It was well circumscribed, and in the histopathology we saw sheets of spindle-shaped cells arranged in the form of fascicles, hypercellular areas. You hardly see any stroma here. It is completely cellular. So such areas are called hypercellular areas, and the shape of the cell is spindle, and they're arranged in long fascicle, long bundles. And some areas there was a swirling pattern, pink cytoplasm, and some areas showed cigar-shaped nucleus. I'll tell you what it is. And mitotic activity was 3 to 4 mitotic figures were seen. So this is a cigar. So when the ends are flat, it is called cigar-shaped nucleus. You see the cell here, and this is the nucleus. The ends are blunt or straight. So this resembles a cigar. So cigar-shaped nucleus is characteristically seen in leiomyoma and leiomyosarcoma. Some other areas of hypercellularity and spindle-shaped cells arranged in fascicles with no cellular atypia. IHC was done. Smooth muscle actin was positive. So the diagnosis was leiomyoma. It is not leiomyosarcoma because it was well circumscribed. There was no infiltration. There was no cellular atypia. That's why it was considered to be leiomyoma. So what is leiomyoma? It's a benign tumor originating from the smooth muscle cell. And WHO definition, it's a circumscribed, benign, often cutaneous tumor composed of intersecting bundles of mature smooth muscle cell. So if you know what is a smooth muscle cell, how does it appear, how do we enhance the smooth muscle differentiation, then diagnosis becomes easy. And it is not common in the oral cavity. 150 cases have been published. It is common in the site where there is smooth muscle, that is uterine myometrium, gastrointestinal tract, and the skin. And it grows slowly. It appears as a mucosal nodule or submucosal nodule, asymptomatic. Occasionally, it is painful. Histologically, there are three types: solid leiomyoma, angiomyoma. This is more common type among the three, and vascular leiomyoma. And this is epithelioid leiomyoma. The cell shape, if it is epithelioid, it is called epithelioid leiomyoma. Angiomyoma, where the swirling is seen around the blood vessels, that is vascular leiomyoma. And so these are the three types. Moving on to the next story of a brittle bone. So brittle bones are seen in osteopetrosis. It is also called marble bone disease or Albers-Common disease. It is derived from the Greek word petros, meaning stone, and a bone means osteo. So the bone literally becomes stone-like. So what is osteopetrosis? It is a group of rare metabolic bone disease characterized by impaired osteoclastic activity resulting in bone mineral density. So the remodeling is affected. There is no resorption. Osteoclasts are not affected. So it comprises a clinical spectrum ranging from very mild to severe disease phenotypes that are fatal in the first year of life. Infants are affected. And why the bones are brittle? Because of the increased bone density, there is accumulation of bone with defective architecture. It is not a good bone which is depositing. That makes the bone brittle and they are susceptible to fractures. So types of inheritance, there are three types. It can be autosomal, dominant, benign type, and the recessive types are malignant and intermediate type. And the clinical features can overlap. Benign type is less severe, and 50% of the cases it is asymptomatic. And skull-based thickening, fracture, facial nerve, cranial nerve palsies are seen. Similarly, in intermediate and malignant. Malignant ones are commonly seen in infants. And many symptoms are seen in recessive type. So in general, osteopetrosis patients stunted growth, head will be large, macrocephaly and frontal bossing, anemia and recurrent infections, hepatosplenomegaly due to bone expansion leading to bone marrow narrowing and extramedullary metaphysis. And because there is suppression or compression of the cranial nerves, the ocular nerve is involved, optic nerve is involved. So that can result in deafness and even blindness because of the pressure points and also facial paralysis. What are the orofacial manifestations of osteopetrosis? It is a rare disease. We don't come across osteopetrosis in our day-to-day clinical practice. But if you know it, diagnosis becomes easy. Deformity is seen, short mandibular condyle, developmental delay of the orbital bone, tooth eruption defects. This particular case, which I'm going to discuss, the patient herself was telling the teeth are falling on its own and some have not fallen. Hypodontia, enamel hypoplasia will be there. Abnormal pulp chambers are present, susceptible to dental caries. Lamina dura will be thick and they're prone for osteomyelitis. The important skull feature is hair on end appearance because of the thickening of the cortex. So there are important radiological features in osteopetrosis, especially when the normal appearing vertebral mid-body sandwiched between the superior and inferior end plates, it results in sandwich vertebrae, or it's also called rugger jersey appearance. Those who are studying for entrance will be knowing this rugger jersey phenomena, rugger jersey appearance is seen in osteopetrosis, or also sandwich vertebrae. And there's one more feature called Ellen-Mayer flask bone deformity, where there is club-shaped flaring of the metaphysis, and skull bones will show characteristic hair-on end appearance. These are the characteristic features of osteopetrosis, radiological features. So 14-year-old female presented to pediatrics with the complaint of swelling in the left back tooth region. And she also mentioned about two draining sinuses of 4 months duration. Her head examination, little macrocephaly was present. And she had some reports which showed it was confirmed to be that she was blind. There was optic atrophy, exophthalmos, nystagmus, and strabismus was present. And cardiac evaluation was already done. There was nothing abnormality, and even brain MRI was suggested. Nothing abnormal was detected. So our chief complaint was these draining sinuses. So when you see draining sinuses multiple in the neck region, you will immediately think of actinomycosis. Sometimes yellow granules will be here. Here there was no such yellow granule. And also you can think of tuberculosis. And it was sent for culture sensitivity. And radiograph was also taken. CBCT was suggested. It showed mixed dentition. Teeth retained were 5, 3, 5, 4. Many were unerupted. 1, 3, 3, 3, 3, 4, 2, 4, 3, 4, 4, 4, 5. So in CBCT, sometimes they also mention which tooth is that. So it is definitely superior over OPG. And you can see, you can trace the nerve. And when you look at the alveolar bone, the bone surrounding the tooth, it was abnormal. You don't see the trabeculation. You can see step ladder pattern in the molar region that was not seen. It was like a ground glass appearance. The normal alveolar trabeculations were lost. It was more dense sclerotic bone, and periosteal reaction was seen throughout the inferior cortex of the mandible. And so the CBCT report suggested to be a fibroosseous pathology because of the ground glass appearance. And there were some radiolucencies here and there. And lamina dura was not made out at all. So that was CBCT report. Some biochemical tests were advised. CBC was normal. Her alkaline phosphatase was 101. She had little higher PTH level. Serum calcium was 9.2. Hemoglobin was low. LFT was normal. Our ferritin levels were low. So considering the sinuses, and in the microbiology report, the culture showed scanty growth of Staphylococcus species, but it was negative for actinomyces and mycobacteria organism. So it was considered to be a type of osteomyelitis. So they removed the necrotic areas from the mandible. So we showed two segments. So one segment showed sclerotic bone and another segment showed necrotic bone. So I'll tell you how do we differentiate between a sclerotic bone and a normal bone and the necrotic bone. So this is the photomicrograph of the normal bone, where you can see trabeculae, and in between you have marrow spaces. There can be adipose and some fibrous component. Look at the sclerotic bone here. The trabeculae are thick and you can see prominent lines here. And also, if you look at the marrow spaces, it is fibrosed. You see a lot of fibrous tissue, less of adipose tissue, and marrow spaces are completely fibrosed, and the trabeculae is thick. This is sclerotic bone. Sometimes this trabeculae, in some areas, trabeculae was seen extending into the marrow spaces. We call this osteophytic extension. So this is you can see the cells here, osteocytes in the lacunae, and there are some prominent lines, resting lines, because there is bone deposition. That was one segment. In another segment, we could see the dead bone and some inflammatory component in the marrow spaces. How do we know the bone is dead? If you look at the lacunae, if you look at the spaces here, it is empty lacunae. There are no osteocytes within the lacunae, and lot of inflammatory cells were present, and the bone is little bluish tinge. So the diagnosis with this, you can say it is osteomyelitis. But what about this sclerotic bone? So why are we seeing this sclerotic bone? So along with some osteophytic extension. So it was considered to be osteomyelitis in a setting of osteopetrosis along with cutaneous fistula. That fistulous area was separately sectioned, processed, and it showed granulation tissue and some bacterial colonies. So that was the diagnosis. So the learning point here is patient was blind, congenitally blind, and she had macrocephaly. Her counts were low, hemoglobin was less, and teeth were not erupted, and the bone didn't appear normal. It was sclerotic. So all these points will help you diagnose osteopetrosis. Patient was suffering from osteopetrosis, and those patients are prone for osteomyelitis. So thorough systemic evaluation is mandatory. Extraction in osteopetrosis is avoided because it might initiate the low-grade infection. They are prone for osteomyelitis, and debridement is not the focus of therapy, and risk of pathological fracture is present. Medical management is preferable than surgical management. Culture-directed antibiotics recommended for cutaneous fistula. So these are the learning points from the case. So moving on to the sixth story of a clear cell. Why any cell becomes clear? There are three mechanisms explained. If the contents of the cell, that is cell organelles, are less or more, it can lead to clearing. So for example, if you take an example of rough endoplasmic reticulum, if it is reduced, the cisternae will show vacuolization that leads to clear cell change. And if secretory granules are decreased and mitochondria is swollen, all these points will lead to clear cell change. That is one thing, sparsity of the cell organelles. Second mechanism is excessive accumulation of intracytoplasmic substances. Maybe glycogen is getting accumulated, or sebum is accumulated, or mucus is getting accumulated within the cytoplasm. That leads to clear cell change, because once we do processing, that substance is cleared, washed, and that gives a clearing area. Then artifacts during fixation and during histological techniques can also cause clearing. So presence of cell, is it always pathological? No. Physiological clear cells are also present. It can be both epithelial and mesenchymal, odontogenic or non-odontogenic. Cells of Malassez and Serrae are clear cells. Your non-keratinocytes like melanocyte, Merkel cells, Langerhans cells are also clear, and mucus cells in salivary glands are also clear. So these are physiological clear. Then where do we come across clear cells in pathological lesions? It can be odontogenic cystin tumors. It can be benign and malignant connective tissue tumors like lipoma, reactive lesions, then metastatic lesions, and even in infection, herpetic lesion, you see clear cell change. So just to give an example of how clear cell appears in lipoma, in xanthoma, this is our own case of verruciform xanthoma occurring on gingiva, and CEOT also, odontogenic tumor with clear cell change, that is CEOT, clear cell variant, and metastatic tumors, especially renal cell carcinoma, can have cell. I'll just show you two cases of clear cell tumors. One is a patient, 38-year-old male patient, female patient, presented with swelling in the hard palate. It was not crossing the midline, well circumscribed, measuring the CBCT report, measuring 2 into 1.5 centimeter. There was slight erosion. The bone was not involved. It was sitting in the soft tissue, firm in consistency. So since it was on the palate, benign salivary gland tumor was considered. This is a CT image, sorry, not CBCT, CT image, well circumscribed lesion. Histology showed three types of cells, some completely clear cells, some intermediate cells. So these completely clear cells are sebocytes. So in sebaceous adenoma, three types of cells you can see. The large cells with clear cytoplasm are mature sebocytes. Some cells with some cytoplasm are called intermediate cells, and the cells which are like basaloid and at the periphery are called germinative cells. So this was a case of sebaceous adenoma. So sebaceous glands are not seen in the oral cavity. Ectopic location can be seen, and it was sebaceous adenoma of the palate. So where do you see sebaceous differentiation? Physiologically, you can see within the major glands, and fordyces spots. They appear like papule, white papules or yellow papules in the oral cavity. They are fordyces spots. And sebaceous tumors like sebaceous adenoma, carcinoma, you can see sebaceous differentiation. And in some salivary gland tumors also use sebaceous differentiation like Warthin's tumor, low-grade tumor, MEC. Adenocystic carcinoma. And non-neoplastic lesions like hyperplasia, somatic synidinitis, you can see sebaceous differentiation. Another case I'm going to show you about clear cell morphology is 72-year-old female presented with pus discharge in the lower jaw since a month, pain in the left side of the mandible since 3 months, insidious in onset, tingling sensation present radiating to the ear. This was little alarming. She had a habit history of betel nut chewing occasionally, and she was a denture wearer from past 30 years. And she was diabetic and hypertension, but on medication, and no regional lymphadenopathy was observed. Intraoral examination, only near the posterior buccal mucosa there was pus discharge, and rest of the areas was normal. Edentulous mucosa, it was normal, and only here there was a pus discharge. CBCT showed irregular, ill-defined radiolucency in the posterior mandible, measuring around 18.4 to 28.2 mm. And it was extending up to the coronoid process. So this is the tracing of the nerve, and the lesion is sitting here. So it was a central lesion, osteolytic lesion. This is a 3D image of the bone involvement along with the inferior alveolar nerve. So considering the clinical picture and the radiologic imaging, primary intraosseous squamous cell carcinoma was considered. And under differential diagnosis, malignant odontogenic tumor, malignant salivary gland tumor, and metastatic tumors was considered. Incisional biopsy showed solid islands. You can see different patterns. When the cells are arranged in particular pattern, we describe that pattern. So if they're grouped together like this, it is called solid island. If they are like elongated structures, we call it cords or strands. And if they are surrounded by some connective tissue, we call it lobule, well circumscribed lobules. And there are some spaces like how you see in lung spaces, alveolar spaces, it is called pseudo-alveolar pattern. So we could see some epithelial cells arranged in various patterns, and predominant areas show clear cell morphology. You can see the clear cytoplasm. It is white in color, and they were quite uniform. Mitotic activity was not much. This is the high power of clear cell with the eccentrically placed nucleus here. Some had nucleus in the center. So by incisional biopsy, we could make out that it is a clear cell tumor. But I just showed you the classification of clear cell tumors. It can be salivary in origin, it can be odontogenic in origin, or it can be malignant. Then we just gave it as clear cell tumor, and it was excised completely. And excisional biopsy, we looked for architectural pattern, morphology, atypia, invasion, etc. For each category, architectural pattern was almost similar to the incisional biopsy. Some areas showed cystic degeneration, and hyalinization was seen. And this is a hyper picture of epithelial cells arranged in lobules, clear cell morphology. And you can see the hyalinization here around the islands. And in one area, we could see columnar differentiation with palisading nucleus. So this mimics ameloblastomatous island, cytoplasmic vacuolation covering VG criteria. So this was the clue that could it be a odontogenic clear cell tumor. Very few areas showed mild nuclear atypia, and few mitotic figures. So atopia was less, stroma was again hyalinized, and it was infiltrative. You can see the residual bone here, and it is completely surrounded by the tumor mass. So it was infiltrative in nature. It was resorbing the residual bone. So metastatic. So you can take the help of the special stains. PA stain was done to rule out the salivary origin, and it was positive because it's glycogen rich. Alcian blue was negative, mucic carmine was negative. So considering the odontogenic island and the special stains, we gave a diagnosis of clear cell odontogenic carcinoma of mandible. Immunohistochemistry was done, but it is not specific. But cytokeratin 19 is done for odontogenic tumors, and calretinine 2. 19 was immunoreactive with a score of 3+ in the lesional cell. Calretinine was non-immunoreactive with the score 0. So considering cytokeratin 19 positivity, we gave a diagnosis of clear cell odontogenic carcinoma of mandible. So earlier it was called clear cell ameloblastoma, clear cell odontogenic tumor. Only 75 cases are reported, and these tumors are seen in elderly with female predilection, common in the mandible. And histologically, you have 3 patterns. I'm not going to that. So differential diagnosis, you have to look for clear cell variant of CEOT. You have to rule out clear cell variant of CEOT, clear cell variant of ameloblastoma. There will be supporting histopathological features when you are doing that. And salivary adenoid cystic carcinoma, MEC, hyalinizing clear cell carcinoma should be considered for DD. Melanomas to an extent, and metastatic renal cell carcinomas. But around the cells, there will be thin capillaries present. So that will be the clue for renal cell carcinoma. So we are at the end of the session. Last story is about black fungus. So we all know black fungus is called mucormycosis. Earlier it was called zygomycosis. It's an uncommon life-threatening fungal infection. Aggressive, it is an infection. It has a characteristic, it shows a characteristic phenomena called angioinvasion. It shows angiotropism. It looks for the blood vessel. It causes thrombosis and infarction. That's why there are necrotic areas. So clinically, a patient may have pain over the sinus region, teeth region, or gum region. A patient may suffer headache, nasal congestion, bleeding, and from the nose, and fever. Paresthesia over half of the face. Then one-sided facial swelling. Periorbital swelling is commonly seen with blurring of the vision. And black lesions can be seen around the nose, inside the oral cavity, especially on the palate and around the orbit. And diplopia can also be seen. So there are 4 types of mucormycosis: rhinocerebral, commonest type; cutaneous, pulmonary is the second commonest type. It can also involve the gastrointestinal tract; and disseminated type, where the brain is involved. So there are many risk factors for mucormycosis. Mucor organism is there in the environment, but the risk factors, when there are risk factors, it starts proliferating. Mainly it is uncontrolled diabetes, diabetes mellitus, and increased iron and leukemias. Nowadays, you can see mucormycosis in leukemic patients. And when there is prolonged neutropenia, immunosuppression, or use of corticosteroid therapy, severe burns, malnutrition, all these factors will lead to are the predisposing factors for mucormycosis. 46-year female patient presented with pain in the upper right back tooth region for past 3 months. She suffered COVID-19 infection and recovery was uneventful. After 10 days of COVID infection, she developed tooth pain, which was mild and continuous and dull aching, and it was radiating to the cheek region, which she got a tooth removed by a dentist. Pain did not subside even following the extraction, and she started having a discharge of about 2 to 5 ml per day approximately from the nose, which was intermittent and blackish in color. So past medical history, she is a known case of diabetes mellitus since 3 years on medication, and she gave history of COVID infection 3 months back, and history of tooth extraction 1.5 and 1.6 3 months recovery of COVID. So intraorally, 1.5, 1.6 region, we could see some yellowish bony fragment. The whole segment was moving. She had a poor oral hygiene. Other teeth present were these, and the sockets were not healed, unhealed extraction socket with necrotic bone seen here. And it was soft in consistency, and that segmental mobility was seen in that region. So it was considered to be osteomyelitis of the right maxilla because of the history of extraction, COVID infection, and the presence of the necrotic bone. Differential diagnosis, mucor was in mind, and aspergillosis. CBCT showed a radiolucency involving the right maxillary sinus, also involving the right nasal cavity. And after preoperative diagnosis of osteomyelitis of right maxilla, 1.4, 1.3, 2.3 were extracted, and the sequestration of right maxilla was done under general anesthesia. And the maxillary sinus was also explored, and necrotic soft tissue was removed along with the sinus membrane, and opening was kept at 1.4, 1.3 region to allow for pack change. So this was the gross specimen received. Teeth were extracted, and this was the necrotic fragment, the unhealed socket you can see, and the necrotic sag, and there was a blood clot, and this is the gingiva surrounding it, alveolar mucosa. Microscopically, it showed foci of necrotic bone with empty lacunae suggesting osteomyelitis. But along with that, there were marrow spaces showed large aseptate hyphae branching at right angles. So this is an area of necrotic bone. You don't see osteocytes within the lacunae. They are empty, bluish in color, and you can see inflammatory component. And bacterial colonies were also present adjacent to the necrotic bone. And in some areas, we could see large aseptate refractile fungal hyphae branching at 90 degrees. Here you can see the 90-degree branching. So PAS can enhance the fungal organisms. It can be spore or it can be hyphae. And here it is, usually they try to reach the blood vessels. You can see invasion into the blood vessels. So aseptate, you don't see septa here, and they're large hyphae. So final diagnosis was given as mucormycotic osteomyelitis of right maxilla. So what is the other organism which is similar to it? That is aspergillosis. There is septae present. You can see the small lines here. These are the septae. And comparatively, mucor is bigger, larger, measuring around 6 to 30 microns. And the branching is seen in both hyphae, but here the branching is at 45 degree. Here the branching is at 90 degree. You can see the 90-degree branching. And this shows angiotrophism and invasion and necrosis of the blood vessels. It can also cause vascular invasion. Nowadays, there is a concept that mucor can also show perineural invasion. So another learning point is there's something called trifungal osteomyelitis. That means we know that osteomyelitis is caused by bacteria. Specific osteomyelitis is when it is caused by actinomycosis, mycetase, or when it is caused by Mycobacterium tuberculous. We call it tuberculous osteomyelitis or actinomycotic osteomyelitis. Trifungal osteomyelitis means 3 fungal organisms are involved. You see necrotic bone, candida organism, aspergillosis, and mucormycosis. We call it trifungal osteomyelitis. So that's about 7 stories. To conclude, most of the times oral diagnosis is a team effort. We need adequate clinical history. We need clinical findings and radiological interpretations, and also surgeons' operative findings. So these things make a difference to the final diagnosis. And understanding the basics and applying that basic knowledge for the clinical diagnosis is very important for the budding dentist and for the clinicians. Hope I have made that point clear, that I have just attempted to make you understand a few basics and its application in the clinical diagnosis. Most of the cases are rare. We may not see in day-to-day practice, but every case is interesting, and it is having a knowledge about it will help you to become a better clinician. Thank you all for your patient hearing. Thank you so much.
Thank you, ma'am. It was really an eye-opening lecture. It was extremely informative. It will be very useful for the audience. Now I would like to invite Dr. Ganapathy, HOD sir, Department of Oral Pathology, VDCW, to felicitate our speaker with the appreciation certificate.
It was an excellent presentation, ma'am. It was explained in a simple way. As a token of appreciation, I would like to share the e-certificate, madam. Kindly accept our e-certificate. Thank you, ma'am.
Thank you, sir. Thank you so much.
Thank you, sir. Thank you, ma'am. Now I request Dr. Saranya, Reader, Department of Oral Pathology, VDCW, to put the thank you note.
A very good afternoon to all. It gives me an immense pleasure to deliver the vote of thanks in this online CDE program conducted by. First and foremost, I thank the Almighty God for making our CDE program a resounding success. We are grateful to our chairman, the living legend, Vidyaratna Professor Dr. M. Karunanidhi sir, for providing this platform for us. He is always the source of inspiration for all of us. My heartfelt thanks to our well-wisher, Dean Professor Captain Dr. S. Gopalnathan sir, for his support for organizing this CDE program. His able guidance has always encouraged us. I thank him for his kindness, support, guidance, and encouragement in all our efforts. I would like to thank our beloved principal, Professor Dr. N. Balan sir, for his kind words and unstinted support in conducting this program. On behalf of our department organizing committee members, I would like to thank our wonderful guest speaker, Dr. Priya N.S. ma'am, for unfolding the stories of pathology, clearing the concepts, and enhancing our knowledge, vision, and understanding on ulcer, impacted teeth, salivary gland, smooth muscles, brittle bone, clear cells, and black fungus. Thank you so much, ma'am, for accepting our invitation to grace this program despite your busy schedule. I would like to thank the HODs of various departments and all my dear colleagues for their valuable contribution in making this program a successful one. I extend my thanks to the postgraduate students, interns, and all the delegates who have worked hard to make this program a memorable success. Once again, thank you one and all. Thank you.
Thank you, ma'am, for your appreciation. I request all the participants to switch on your video for group photograph. Thank you all participants.
I think there are some
Now
questions.
there is a question in the chat box, ma'am. Can you kindly answer?
You can see the question. One is how to histologically differentiate initial stage of dentigerous cyst and the enlarged dental follicle. Okay. So the hypoplastic dental follicle sometimes have a lining resembling reduced enamel epithelium, but it will not be intact. You can see the fragmented portion of reduced enamel epithelium, but in dentigerous cyst, it will be throughout seen. And radiologically also, if it is the space is less, you can differentiate between dentigerous cyst and enlarged follicle. But histologically, the continuity of the lining will be more evident in dentigerous cyst, but not so in hypoplastic dental follicle. What could be the diagnostic and treatment follow for trifungal osteomyelitis? So in trifungal osteomyelitis, since all three are fungal infections, antifungal therapy will play a role, but it is a very, very rare event. Only 1 or 2 cases have been reported, especially in the mandible. So antifungal therapy is initiated, and surgically, depending upon the necrotic thing, surgical debridement followed by antifungal therapy. And again, the protocol is followed for systemic antifungal therapy with regard to creatinine clearance and all that. So it will be same like treating single fungal infection and trifungal infection.
Any other questions? Thank you, ma'am. It's time to wind up our program. Thank you all for the encouragement and for giving us your precious time. Your presence made this day amazing and interesting for us. Thank you once again. We can close the session.
Thank you so much. Thank you all for the opportunity. Thank you so much.
Thank you, ma'am.